Beautiful.
Okay. And we did have 15 folks register, which is like a pretty good
Yay.
yeah, registration response. And I see a few other students in. So I'll probably let folks in and kick us off right at 6 o'clock, but no, there'll probably be some others joining. I
Perfect.
guess. Yeah, Daniela, did you have any other like instructions or did you guys have any other questions for how like the format of it will go?
Yeah, I mean, all I really do is give you guys the chance to introduce yourselves. Then I might start with something like, maybe tell us like a little generally about what you do or what your day-to-day looks like. And pretty quickly from there, I just open it up to prospective students or anyone in the crowd just with questions. And again, sometimes they're really specific, sometimes they're more broad, sometimes they're a little bit more admissions based, and I will do my best to help with any questions that I can if they are that broad. Does that sound okay? Perfect.
Perfect. I have a question. Are you guys still offering like the modalities certification
Yeah,
as part of the curriculum? Okay, cool.
yeah.
Yeah, and
Great.
if you want to like say something about that, how useful that's been, that's
Yeah.
great.
Yeah.
I can also include that infographic we have about that,
Yeah. Michelle's
all
really good
about all
about
the different
like
things we
dropping
offer, the
links
other
if
programs
like
on offer.
like
Yeah.
people have
Perfect.
asked about housing before and Michelle's like, here's a link for that. Here's her transportation. She's awesome.
That's super helpful.
Yeah. So we'll be around fact checking you guys in case there's any changes. Of course, like not really fact checking you, but if
Yeah.
we need to clarify
If
anything,
things have changed.
yeah, we
Right.
can like chime in. So thanks Michelle for dropping that welcome note in the waiting room.
Sure.
It's 6 o'clock. Are we ready?
Good to go.
Ready?
Good evening, everyone. Thank you so much for being here. It's a very kind of cozy, rainy night here in Chicago, as I know many of you are, but maybe folks are joining from other locations. We're excited that you are taking the time to join us. My name is Bridget Hahn, and if I don't know you, I see quite a few current students, which is great. And then I also see some prospective students, which we're really happy to have you here as well. Prospective students are able to earn 1 observation hour if you're working on your application for OTCAS for Rush. It would count towards our required 20 hours of observation. We have a lot of upcoming recruitment events, so make sure to check out our website, however you registered for this link, and follow our social media at the Rush underscore OTD underscore the number two to be two and then BBE. And I can drop that in the chat too. When I was promoting our Instagram, we like to have a lot of fun with that. I realized I got excited. I'm talking about you all, but I did want to just say that I'm the director of admissions here and the assistant professor. I'm joined with my counterparts in the admissions office, Michelle McFall Johnson, and then Daniela Ugalde is one of our former student admissions committee member who's graciously agreed to serve on the admissions committee as an alumni and has really been pivotal in introducing some really innovative ideas for not only like recruitment but community building across like the Rush OTD group. So I'm really excited that she's here and we're going to learn a little bit more about hand therapy today. So a big thank you if I'm not able to be here during the end to officially thank you all, both Daniela and Chloe and Carly, who are other alumni, for their time. Okay. I know they
Before
got
we
a lot of good stuff.
start,
I got to stop talking.
yeah, before we start really quick, if you're in as a phone number, if you could put it in the chat to me directly, like who you are in your email, so that if you are earning a CEU, I can make sure to send that to you afterwards. If you're someone who's jumped in and you didn't previously register, that's just fine. But also I'll need to have your email so that I can send you the CEU and the follow-up email with information. Thank you.
Thank you, Michelle. Thanks, Bridget. My name, like I said, is Daniela Ugalde. I am a Rush OTD alumni. I graduated in April of 2024, so about a year ago. And like Bridget said, I serve as an alumni member on the Rush admissions committee. And for me, these Q&As are actually very special to me because the time that I was applying to OT school was in the middle of the pandemic, where it was really difficult to get observation hours, to get that one-on-one time with other clinicians. But something that was really special to me is I just joined a bunch of Facebook groups when I was a student, and got to talk to a lot of clinicians that way, actually. A lot of them offered their time to FaceTime with me or video chat or text or email, whatever they could at the time. And that's how I got a lot of my experiences. And so, after graduation, I was really thinking back of like what we could do to really help connect our communities, current alumni, students, future students, in order to give ourselves that opportunity to be able to learn more from one another and really unite as a community of occupational therapist practitioners, students, and again, maybe prospective students as well. So we try to do this about once a month, featuring different communities, different people in the OT community. And today, specifically, we're focusing on hands. So, little bit want to introduce Carly and Chloe, who have graciously to Rush OT alumni, and I'll have them introduce themselves.
Chloe, I can start. Hi, everyone. My name is Carly Ebert. I graduated Rush OTD program back in 2023. So I can empathize with that COVID pandemic education. So hopefully nobody's going to have to go through that again, but it was a very interesting time to be going back to school. I'm originally from St. Paul, Minnesota, graduated undergrad from the University of Wisconsin-Madison, and then found my way in Chicago at Rush University. After graduating, moved out to Denver, Colorado. So I've been practicing full time in hand therapy since graduating in 2023. So I've loved every minute of hand therapy. I didn't know I was going to start in hand therapy. I always thought I would be in the more acute care ICU setting. But when I was randomly placed at Northwestern for a level 2 clinical rotation in hand therapy, I was like, this is it. This is what I want to be doing. Loved it so much that I continued my capstone experience in hand therapy at Rush, their Midwest Orthopedics at Rush. And then I was really lucky to find a job right away in hand therapy, which can be kind of challenging as it is a specialty area, but haven't looked back, and I'm looking forward to sitting for my certified hand therapy credentials in November of 2026 when I'm eligible to do so. So I'm excited to hear all of your questions about hand therapy moving forward.
Awesome. Hi, I'm Chloe. I graduated from Daniela's class at Rush, so 2024, very similar COVID application process, as we've mentioned. I'm originally from actually the Denver, Colorado area and moved out to Chicago for undergrad. I went to the University of Chicago out here, loved Chicago, didn't want to leave. That led me to Rush. Initially wasn't sure I was interested in hands as well, but going through anatomy, learning more about the different areas of OT, hands kind of stuck out to me. Loved my level 2 rotation at the University of Chicago in their outpatient hand clinic, and then was lucky enough to get hired on at Midwest Orthopedics at Rush right after I graduated last year. So I've been there for the past year. I'm a float therapist, so I go to all of their different OT clinics in the Chicago area, and it's been an awesome learning curve for the first year here, but wouldn't have it any other way.
Thank you both. I think just to start us off, I would love to hear a little bit more, maybe what your day-to-day looks like, either what you commonly see or what you're commonly doing. And then afterwards, maybe we can open it up to the audience. Sound good?
I can speak on that. So I currently work for a private practice physician-run clinic. It's the Orthopedic Centers of Colorado in Golden location currently, and I'm actually about to transition to a new position with UC Health Stedman Hawkins Clinic in June. So it's going to look a little funky for me in the next like month or so, but my typical day treating patients, I work 410s, which was another reason why I really liked hand therapy. No weekends, no holidays, 410s, you get a day off in your week. And typically most outpatient clinics are very flexible. I haven't really found a clinic where you can't kind of make your own schedule. So if you're looking for a little bit more flexibility, great setting to look into. I treat, I would say maximum of like 13 or 14 patients a day, 40-minute time slots with kind of a break in the middle. I'm currently in a more non-traditional hand therapy setting. I'm actually one of 2 full-time OTs across 3 locations. So definitely looked a little bit different than maybe what Chloe will share at MOR or Midwest Orthopedics at Rush, where it's very collaborative. So one of the reasons why I'm also leaving, to get a little bit more collaboration with other OTs. Very challenging as a new grad. But it's busy, it's fast paced, you're evaling patients, you're doing just typical intervention, like daily treatment sessions, and treating pretty much everything from the shoulder down. In my clinic, the physical therapists that I collaborate with tend to take more of the shoulder patients, so I treat primarily elbow down, anywhere from fractures, soft tissue injuries, nerve compression injuries, tendon lacerations, conservative arthritis. And then there's always some kind of interesting things that'll pop up every once in a while. I collaborate with 2 doctors down the hall, which is great. We do a lot of modalities, so ultrasound, e-stim, heat. You'll do some manual therapies, so stretching, hands, wrists, fingers, and then kind of taking patients through a lot of functional activities. I focus a lot on getting patients back to doing what they need to do and they want to do. So always tapping into some of those OT things, even though it's definitely more biomechanic focus in hand therapy.
Awesome. I definitely have a similar setting that I work in as well at MOR, like Carly was mentioning. So Midwest Orthopedics has 8 different clinics with hand therapy at them with OTs throughout the Chicago area. So depending on what clinic I'm at, what day of the week, what doctors are in, my day looks really different. So MOR is really cool. We're directly affiliated with the orthopedic surgeons at Rush. So we get all of their referrals for the most part. We do outsource a couple other clinics in the Chicago area. We have a pretty good partnership with Athletico and just some other hand therapists in the area. But for the most part, all of their patients come through us at the various locations. So depending on the day, I'll either treat my 10 to 12 patients in typical treatment sessions like Carly was talking about, all of the different modalities. We'll go through a lot of therapeutic exercise, but then we also really try to focus on those activities, those daily skills, return to work stuff. Or we also will have walk-in days whenever the doctors are in clinic. So we'll do splinting for any and all of their patients. So they'll send over people after they've seen them for check-ins, depending on what they need. We'll make them wrist splints, finger splints, elbow. We work primarily elbow and down as well. Most of our PTs take the shoulders. However, we do a lot of bicep and triceps repairs. So absolutely depends on the day. So today, for example, I was split half a day in the splint room in the morning, so splinted all morning and then came downstairs and treated for the afternoon. So that looks a little bit different. Sometimes it's slower. Sometimes you have 6 splints and then you go to lunch like I didn't blink and then treat your 7 patients after lunch. Like, oh my God, today was a whirlwind. But some days it's really nice and kind of slow. And then out in the suburb clinics, usually there are also doctor clinic days that have a similar flow to them if it's a doctor day. Yeah.
Midwest Orthopedics at Rush was wonderful. If I was staying in Chicago, Northwestern was also amazing, but I really loved my time at Rush. I don't know, do you work with Kelly at all? She was my supervisor, love Kelly. But that was one really special thing I think about Midwest Orthopedics at Rush was their walk back splinting. That is not common in hand therapy clinics. I've found a few clinics out here in Colorado that have that, but typically, if you're getting a walk back splinting patient, like they need something custom or they lacerated their flexor tendon, they had surgery, you got to get them in 2 days later. You're fitting them in between your typical patient caseload. So that can add up to a lot of patients. But if you like that fast paced, sometimes crazy setting, hands is definitely for you.
I love it, and I love to see the connection already, which happens a lot actually in these alumni Q&A, so I really enjoy that and I enjoy seeing that. I'd love to open it up to the rest of the group. Feel free to unmute yourself if you have a question, or you can throw a question in the chat and I will read it out loud.
Carly, I have a quick question. You said that you did your capstone at Midwest Orthopedics. Do you mind sharing a little bit more about that?
Yeah, absolutely. So kind of during your time at Rush, I think like your second year, you start planning for your capstone project. And so I had started maybe like a few weeks into my level 2 at Northwestern Enhanced. I was like, oh, I think I like this. I remember collaborating with like my capstone mentor, who's going to be one of the faculty professors. And I was like, I think I really like hands. And he goes, we haven't had a student go to Midwest Orthopedics at Rush for a while. Did you want to do your clinical experience there? And then I was able to design my experience alongside kind of the research project that you're required to do, also as part of the capstone kind of experience. So I took more of like a clinical and then research based. So I was pretty much just treating for like 35, 36 hours a week. And then I was also working on like a retrospective research project looking at how pain impacted perceived progress in hand therapy. So I did that by having some of the OTs start to take data for me based off of some self-reported questionnaires, then looking at that data, analyzing that. But I was lucky because I just designed it because I just wanted more clinical experience. So I was able to pretty much get another almost 3 months of hand therapy experience before graduating, which is unique and something that I feel like was able to get me a hand therapy job outside of kind of my Chicago network as I was looking for job opportunities. So definitely, if that is an interest of anyone out there, when you're starting to plan your capstone project, I would talk to your supervisor and be like, oh, would Midwest Orthopedics at Rush, would Northwestern, would another kind of outpatient hand therapy setting be willing to have a student there? And kind of mimic that off of like a level 2 fieldwork experience.
And just to piggyback off that, we did have 2 capstone students here this past spring that were both rock stars. One was downtown and one was out in Naperville. And they both had really cool projects. I couldn't even go into depth into both of them if I tried, but both treated a huge amount of patients, and just so fun to see students come in and do really cool out of the box things like that in the setting.
That's awesome. It's great to hear about like how capstone can kind of be embedded into this and very naturally. And again, like it's just one of those great opportunities to take like a really like kind of take a hold of your education and make it what you want it to be, right? We have some questions in the chat. One is, what is your favorite thing about working in hands?
I think for me, it's definitely that every day is different and every day is a fast learning curve, but I like the fast-paced life. And Carly kind of mentioned that you learn as you go and you get that experience day by day. I feel really lucky at MOR. We also get mentors that have been treating. I have their CHTs they've been treating for years. My mentor has been treating for like over 30 years. And so anytime I have anything that comes up that I don't feel prepared for, I know I can shoot her a message, give her a call, whatever. She's there. But also, it's really fun to get something that maybe 2 months ago I wouldn't have been prepared for. But now I'm like, yeah, and we just covered this last week. I know exactly what to do. Bang, bang, bang. And so I love that direct translation that happens a lot. And then on the opposite side of that, I also kind of like the learning curve of, wow, that wasn't my best treatment session. And here's all the reasons I think why. Like, I love that you get these relationships built with other therapists, with the folks you're treating, and you really get to understand, like, okay, this is what you need from me.
Yeah, definitely. I love the collaborative nature. I didn't get as much of that maybe at like my acute care rotation, although that was also a unique experience because I was in Rochester, Minnesota at the Mayo Clinic, and that was, I think, 3 students all going through kind of the same field work experience. But what I learned really quickly after coming off of the acute care and going into hand therapy after, I like the relationships I'm able to build with my patients. In acute care, especially, I was on the oncology floor. Like, you see the sickest patients, and then you get them better after, like, or they transition off the floor because they've discharged for something else, and you don't always get that continuity of care that you get in hand therapy. We'll sometimes see patients twice a week for 3 months, and you really get to build those bonds. And I really like to talk, so I get to talk for 10 hours straight, and I get to educate my patients. And you also have a really strong mental health focus in hand therapy. I bet Chloe can speak on that too. But because you're sitting down, you're across the table from another patient, you're really doing a lot of hand holding. So you get to tap into a lot of the mental health courses that you'll take at Rush, even though you're not in a true mental health setting. There is just something so unique that I feel like my physical therapy colleagues can't really speak to on the impacts that patients will feel on their mental health when they've injured their hand. So I think that that's been kind of a really something maybe I didn't quite expect, and something I've really enjoyed working in.
Beautifully said, and truly, again, kind of highlights that distinction of OT. I love it. What class at Rush did you learn the most from about hands?
I mean, I might need help with this, ladies. It's been a couple years. Anatomy. So you do, I think, like 3 separate blocks in anatomy, and one full block is all on the upper extremity. And you get a cadaver lab, which is fantastic. I also wasn't there when, did you guys, is it the animatron? I don't, how do you pronounce that? What's like the big table anatomy thing? That was not there when I was there. Yes, thank you.
Hermitage table.
That
Yeah,
is so cool. I wish I had that when I was in OT school. I think that is something that is so useful when you're learning anatomy in like before and after you're going into your cadaver labs. So you kind of get your first like taste of hands in anatomy. And then I think we touch on it a little bit in the neuro classes, as well as our like physical disability courses. I remember a certified hand therapist, I think from Northwestern, came in and did like maybe like a 2-day, like 6-hour lecture on hand therapy. So that was kind of a nice overview as well. I'm not sure if I missed anything else, if we wanted to add classes in there.
The only other thing I'd mention is that we get all of that modality understanding, and that I think, is it just the modalities class? Is there, what's the name of that class I'm thinking of?
It's that certification. So
yeah.
I believe in like the state of Illinois, all healthcare providers need to be certified in modalities. And that is one really unique thing about Rush is that's built into the coursework. So you graduate with that certification. So in Colorado, I didn't need that, but at least I had all of the education on why we're using modalities, evidence-based research on the modalities, and then like how to set up. And so modalities being like ultrasound, electrical stimulation, heat, ice, iontophoresis, fluidotherapy. So
Absolutely. It was so nice too, coming out of grad school and being able to, when I started work, jump right into all of those. I didn't have to wait to go get a certification. They hired 2 therapists when I graduated, and I had mine and the other did not. So it was the first couple of weeks, I was the only one that was able to do ultrasound, or if we were doing NMES, anything of those sorts, it was, if it had to fall into one of our schedules, it was always mine. So that was kind of a really nice perk to graduating with that certificate in my back pocket already, as opposed to having to wait for the next cycle to come around to get all my hours done.
That's awesome. Okay, next one we have is, what is one unexpected challenge you faced in hands or during your first job?
This for me definitely ties directly to what Carly was saying with the mental health side of hands. I think that's something that I find to be so challenging depending on the day, depending on the patient. Sometimes when I'll float in to cover for somebody, I won't know their patients as well as they know them. And I find that to be really hard. And I know it's hard on patients sometimes too, especially when they're going through something traumatic and they need to be seen. You know, a lot of these folks can't skip a week of therapy. So they kind of have to give their trust to me. And sometimes that means unpacking trauma again. Sometimes that means having to re-explain what's been going on. And I think that that physical connection, that literal hand holding that does occur throughout our session really brings emotions up for folks sometimes that is hard to navigate, and something that, again, I don't know if I truly knew walking in after just a level 2 what that would entail. It definitely has become one of my favorite parts of the job now, but it is so challenging at times, especially, 7 a.m. on a Friday, and you're like, this is the last thing I want to be doing, but it's so necessary.
yeah, definitely. Very challenging, especially when, you might get a patient that you clash with a little bit, always tapping into like those. I'm like, what mode do I need to pick today? I go back to like IRM. I'm like, can't believe I even remember that right now. But it's like you're constantly shifting to ensure that the patient is getting the most out of the session, using our therapeutic use of self. And then, of course, pain management, that has always been a challenge. So building self-efficacy, I do a lot of education in my sessions, looking at the anatomy. What do these, pain responses mean? So that at least patients have more of that self-efficacy when it comes to their recovery. So that has definitely been challenging. And then also just being the only OT as a new grad has also been challenging. So I would say definitely advocate for yourself. That was something I did a lot when I was actually job searching. And actually a reason why I didn't get a job someplace, because I said I wanted mentorship and they're like, we can't offer that to you right now. And I'm like, that's fine. They ended up reaching back out a couple months later when I had already accepted a job. So if you feel like you want mentorship, especially in a specialty setting like hand therapy, I would encourage you to, say no to jobs, or, it hurts to get rejected, but like it is a good thing as well. So, yeah, the day to day, or two, when you get like a diagnosis you've never seen before, and then you're also alone. And I'm like, I have never seen this before. Like, I don't know what to do. Like, what's safe? Can I start mobilizing it? Like, or should we start therapy? So, talking to the doctors is challenging sometimes when you're like not sure and you don't really know the doctor and you're a new grad and you're like, am I allowed to be talking? Like, do I know enough? It's a little bit of like an imposter syndrome sometimes too, but you just do it because you're an OT now. So that's your job, and you just kind of rip the Band-Aid off. But lots of learning curves. You'll go home, you'll probably cry some days, but you have your self-care, so you'll be okay.
Absolutely. There are definitely some challenging days, right? Like in any job, but hopefully some rewarding days sprinkled in too. I think that touches really nicely. And like you were speaking about the mentorship piece, Carly, is we had a question asking, did you receive any mentorship in your job to support you through the job transition? I don't know if you have anything else to add on to that, Chloe or Carly.
Yeah, I definitely feel like I was so lucky with MOR, the way that they transitioned me into my job and into just in general hand therapy. I have a mentor that I get one-on-one time with every week, starting from the first week I was hired to a full year in. So I actually have a couple more weeks going strong, still left, but she's amazing. She's a CHT. They paired me with her based off of her interests and mine, and just in general where I'll be floating to the most, where I go the most. And then on top of that, they also do a lot of mentorship through connections to our surgeons and our doctors. So within my first couple months at MOR, I was able to go watch surgeries as well with one of our hand surgeons. So they do a great job of, hey, Chloe, come here, come look at this hand that I'm doing something to, and walking me through the anatomy, telling me about, and I like my rehab to look like this, whereas, some of the other docs in the clinic maybe like this or like that. And so it's a very collaborative group there, that the surgeons even take interest in our mentorship because they understand that, hey, like, you're the one who's rehabbing all of my thumb CMCs. I need you to know what I want and when I want it done. And there's definitely a sense of pride that comes with that, I think, too, for us as OTs, being like, oh, you value me, you care about my learning too. So that mentorship piece was just surreal and very, very helpful.
Yeah, and that looked very similar. I had a year of mentorship where we had pretty much a meeting once a week, or I would just call the other OT on staff whenever I like had questions, which was a really nice time to like sit down and be like, okay, what does this protocol look like? What should I do with this? And then kind of collaborating based off of that. And then kind of into my second year now, a little bit less. And now, since I'm planning to sit for my certified hand therapy credentials in a little over a year, I'm like, okay, I have built such a great foundation of hand therapy skills, but I still need to develop in this area, So this new job that I'm transitioning to is guaranteeing now mentorship even 2 years into my career. So I think no matter where you are along your career timeline, I think you're always going to have mentorship, especially in hand therapy, because it is such a collaborative setting. Typically, it's like 4 to 10 OTs all sitting in one clinic, all treating at the same time. So you can even like grab your coworker sitting next to you and be like, what do you think? How do you think this wound looks? Or I've never made this splint before. How do you make yours? So there's a really nice thing where maybe you don't get that as much in like acute care because you're kind of floating across the floor a little bit more. So yeah, great mentorship opportunities in hand therapy.
This next question is getting a lot of love in the chat, and I actually really appreciate it too. It says, how have you ensured you remained occupation-based rather than shifting solely towards the biomechanical model?
I really challenged myself to do this because I didn't go to PT school, and I get called to PT every single day. Um, I I focus my evaluations on occupation. So one of my biggest questions that I ask all of my new patients is, what do you need to get back to doing? And then based off of what they tell me, I write all of my goals with a biomechanical focus. So, how many degrees does a patient need, but to do what? And then I relate that back to their goals. And then throughout the entire treatment session with them, over however many sessions that they need, I try and tie in those occupations that are meaningful to the patient, because nobody's going to do their exercises if they're not motivated. I always say, well, is your hand functional? I can always guarantee that for a patient. I can guarantee function, but it might not look the same as it did before you injured it. So occupation-based interventions are a priority for me. So I always look like the crazy one in the clinic because I'm like running around trying to simulate things where my PT colleagues don't as much. So, if I have athletes in the clinic, I'm bringing out the golf clubs, the tennis racket. If someone's challenged with fine motor and they need to tie their shoes, we're working on shoe tying, buttoning. I do a lot of like jar twisting, bottle cap twisting into putty, pinching, pulling, very functional motions. Because that's ultimately why people are in therapy, is to regain function. And I don't really care if it's that pretty or not, but I care about function. So.
Absolutely. I think also something that helps me sometimes is when I'm working with the patient, we're talking about home exercise programs or things to start doing at home. I always try to frame it in terms of, okay, like, have you been brushing your teeth with your right hand? No, let's do that tonight. Let's do that tomorrow morning. And then when you come back in 2 days, I want you to tell me how it went. And then we can maybe try washing your hair or brushing your hair. And I like to try to incorporate the home exercise program. That's not just like, oh, but like sometimes we really just hone in on, okay, you want to cook dinner tonight? Let's plan out something like go cook dinner tonight and like tell me how it goes. Like I want to know what was hard, what was easy. Could you move the pot? Could you fill it with water? Could you strain the noodles? Like turning that into their home exercise program as best as you can, no matter what phase of rehab they're in. Sometimes that's easier said than done. But trying to tailor, okay, now you're cleared for strengthening. So that means you could try to lift the light pot in the kitchen, use both hands, be safe about it, but tell me how it goes, you know?
There is no better exercise than your daily routine. So sometimes when patients are really challenged by some of those more just like isolated exercises that we might give them, I'll just be like, just don't do that for a day and just do your routine. And then typically patients come back and they're like, oh, I feel so much better now. And then we can start adding a little bit more if like I noticed something else more biomechanically going wrong. But yeah, I always tell patients, if you're functional, you probably don't need us anymore. So that is always the end goal.
I will say on a personal note, my future mother-in-law is seeing a hand therapist right now. She injured her hand, and she will say that that is maybe her favorite thing about therapy is that they always try to make it very functional so that she can do the things that she needs to do at home. Which is probably my favorite part because that very much is the essence of OT. So I love to see you both kind of incorporating that in your own ways in your treatment. It's beautiful. Next question we have is fieldwork the only way that you see different types of OT, or did they talk to you about them in different class too?
You get immersed into all of the different types of OT settings. I think from day one, you're going to learn in your classes kind of about the different settings that you can go into as an OT practitioner. And then you get a little bit more observation during your practicum experiences, which also start during your first year. And then, kind of based off of that, you're able to then we kind of do a lottery system for your field work. And so then based off of the lottery system and then your past experience in practicum, um, also just during the classes, through talking with your professors, through your own research, you get to rank all of the different fieldwork settings. And then you kind of just not randomly, but lottery system, you get placed in those. And typically, and I might need some help with this, Michelle, I think you have to have one in a mental health setting, and then you have to have one in a physical disability type setting. And then the
Yeah.
other two can be kind of anything else. So like pediatrics, yeah.
Part of that is the ACOT requirements,
Right, that
and
too.
part of that is what the program thinks you need to pass your NBCOT. So we're prepping you for that from the very beginning. And the mental health can be in either a level 1 or level 2, but you have to have a FISDIS and a level 2. One of your level 2s has to be a FISDIS. That's correct. We just did the lottery this week, so
Oh, so
it's fresh
fun.
on my mind.
Yes.
We love a good lottery system. I will say though, something about Rush in particular, they do a really nice job of like, I would say faculty in particular. Yes, it is still a lottery system, but they do a really nice job if, if I talk to, if I talk to Michelle, if I talk to Bridget and I said, hey, I love hand therapy and I really want at least one of my experiences to be in hand therapy, they will figure something out for you. They will do their best to accommodate or get you even a place that like, hey, you're doing hand therapy part of the time, but you're also doing neuro and you're also doing something else, right? They did a very nice job of, I think, designing it. And I know particularly for our class, Chloe, I think out of what are we, 36 students, I think people only, again, and every 36 students has four possible like placements. I think only 4 or 5 got non-preferred or non-ranked places, which was wild to me. So it all works out. I think Rush does a really nice job of, again, like allowing you to personalize your education and exploring what you think you might be interested in.
You can also put what you don't like when you're ranking. So I wrote in all caps, no peds, please. And they did not put me in pediatrics. So it goes both ways.
Absolutely, absolutely. Next question we have is what percentage, roughly, of patients do you see with open wounds, blood, stitches, etc.?
I can start here. I definitely see a lot. I wouldn't say that I'm known for not, I'm a very squeamish person and I always have been. So going into healthcare in general, I knew that part of the reason I went into therapy over other realms of healthcare was because I didn't want to deal with a ton of like fluids all of the time. But that being said, I do see wounds, blood stitches every day, whether it's over under 5 patients, kind of depends, but every day. And I definitely have settled into it and now love it and have taken a love for wound care and understanding like all that goes into wounds. And I think it's very different to see wounds, blood stitches, all that stuff in the outpatient scenario compared to my other level 2 was in an inpatient hospital. So it's a very different kind of exposure to those things, depending on the setting you're in. I prefer this outpatient level a lot more, being a more squeamish person. But that being said, I've settled in and come to really be fascinated by a lot of that stuff. So don't knock it till you try it.
It also depends on the clinic settings. So I don't tend to see as many post-op like wound care type patients because we have a cast room and the cast techs kind of take care of that before I see the patient. In more traditional hand therapy clinics, such as MOR, you might be removing the stitches. I don't do that in my clinic. I wish I did. I like the wound care aspect of hand therapy. So you can also find a setting where you're not doing as much wound care either. So if that is something that worries you, you can find it. You can find a hand therapy clinic that doesn't focus on as much wound care. So it's out there.
Next question we have is how do you guys time manage documentation and also seeing 10 plus patients a day, especially as a new grad?
If you find a good clinic and you advocate for your mentorship, they should wean you into it. I think I had almost like a 3-month grace period of being able to put blocks on my schedule to allow for like ample time for documentation. I'm not going to lie though, because we do so much hands-on work with our patients. There are days where I'm like, I haven't wrote a single note today. I have gotten better at just like turning away for like 5 seconds while like, oh, someone's in the hot pack or they're doing their exercise and like getting caught up. But I struggle with that because I know that the patients are there for our time. So that's something I'm working on as a new grad, is kind of juggling doing my notes while I'm working with patients, or am I just okay knowing that, yeah, I might have a few notes to write at the end of the day? So at the beginning, they'll ease you into it. And then you also just get faster at documentation. Like I use a lot of smart phrases. So I'll carry over a lot of the same goals and then just like fill in the blank. Or a lot of my eval templates kind of look the same, fill in the blank. So then it hopefully doesn't amount to too much, but not to say that there isn't a day where I have 11 notes to write and it's 6 p.m. So
Yeah, this is a balancing game for sure. I think that when I first started, it was something that I didn't even think about because I had some time blocks and I only saw 3 patients before lunch and 3 patients after and yada yada. So easy. But as you get weaned in, it is definitely it's still a learning curve for me as well. I definitely prep my notes really heavy the day before always, so that typically by the end of the day I am finishing, because I'm a big, like, I don't want to do it at home. I'd rather get to work an hour early and heavily prep everything and then be out when I'm done. So that's kind of my workflow now. I've found it what works for me. And it's definitely gotten shorter and shorter as I've gotten a little bit more of a handle on what my flow looks like. And, when I can jot down a couple things in between folks, or at lunch, I pull my computer out for a couple minutes after I eat to keep up always, like, religiously. But that lets me leave at the end of the day. So I'm like, I'll do it. And I think too, just because I float, I'll see patients that aren't necessarily mine. So those days I have to heavy prep, or I'm not going to know what I'm walking into. But then when I'm back at my more home clinic, I don't necessarily need to prep nearly as heavy because I know all of the patients on my schedule. So that depends a little bit too on like how the note flow goes. I can look at an afternoon and be like, I'm going to be behind. Or, oh, you know what? I'm gonna be out of here right at 3:30. So it just depends.
floating as a new grad is really impressive. You have probably learned a lot of great independent skills as an OT. I have had the luxury of being able to just like manage my own caseload, but whenever I have to float to the other locations, I'm like, oh my gosh, like what am I doing here? Who am I seeing? So you almost feel like you have to do like a mini eval every single time you meet a new patient. So props to you on that, because that is challenging.
Yeah, floating's not for the weak. It's something that even I worked at an outpatient PT clinic when I was in grad school, and the head PT there that I worked closely with, he started his career floating and told me when I was there, like, if you get the chance to float, like, take it, because you are going to learn so much in the year or two that you float in comparison to not. And I was very hesitant to, I was like, you're crazy. But then now that this is the job opportunity that opened up, this is where I was. And I said, you know what? The world works in mysterious ways, and I have loved it. I do feel like I've learned a ton. There are days that are scary and that are new and that are long, but I think that I've loved the opportunity to flow and meet different patients, different patient populations, because the people I treat downtown versus the patients I treat in Naperville, very different. And I think the surgeons that work here downtown are very different than the ones that are out there. And so it's just been the best learning curve too for hands in general. Like, more exposure, the better.
Absolutely. Absolutely. Mad respect, Chloe. Next question is, and I like this one. I might customize it a little bit. Can you give a specific, or can you give an example about a specific hand treatment? And I'm going to add in if there's a favorite condition that you like treating.
I can tell you what I don't like. Tennis elbow. But actually, that's also a very OT diagnosis to treat. So tennis elbow or lateral epicondylitis is just like a common repetitive use injury of our wrist extensors as they attach on the outside of the elbow. And so typically patients come in and they're like, my elbow hurts with everything that I do. And so a specific like hand treatment for that we do a lot of ergonomic training. So it's a lot of education for that diagnosis. Because if you continue to do the things that provoke the pain at the elbow, it's never going to get better. And so repetitive wrist extension and any type of like extended arm palm down lifting is going to provoke it. So we're talking a lot about symptom management, what to avoid, and then what we're going to do moving forward. So typically that looks like a lot of heat, massage, because we want to promote blood flow because it's not a true inflammatory process like we thought it was. It's actually micro tears in the extensor mass as it attaches on the outside of the elbow. So we're promoting heat and then we're gently stretching it. And then over time, we're talking about ways that we can avoid those repetitive provocative motions. So I'm doing a lot of workplace ergonomic setup. So I always go back to one of the classes, and I actually think Bridget maybe looked at this assessment. It's called the Rapid Office Strain Assessment. I don't know if that was an assignment that you guys had to do in your class of 2024, but I think it was Bridget. She made us go home and look at our, like what we were sitting at and studying at. And we had to assess our desk and our chair to see how much strain it was putting on our bodies. So I actually give that to my patients and I teach them saying like everything in this column, do this. This is what you should look like when you're seated there. And so then moving forward from that, it's like, okay, symptoms are better managed. You know, they're not doing these provocative motions. Now we can start strengthening. Also, there's new research to suggest that people who develop tennis elbow have really weak rotator cuffs. So we're doing a lot of proximal stability. So if you are weak in your core and your shoulders, it puts more stress on your distal extremities. So we're talking a lot about how we can stay stronger here so that things down here aren't hurting as much. So it might be my least favorite diagnosis to treat, but maybe it's one of my favorites because also patients tend to feel pretty good after a few sessions. So, and then ideally they're just managing because it can take like 3 to 6 months, even up to a year for full symptom resolution.
I think that's a really hard question because I see a lot of trauma and like one-offs. So I think that that's a little caveat to this, but I definitely have found, I think similar to Carly, that some of these more run-of-the-mill, maybe seemingly boring diagnoses, I find to be the most beneficial, not only for my learning, but also like I feel the biggest impact with patients. We see a lot of CMC arthroplasties, so just helping with a lot of people have arthritis at the base of their thumb. And so we have a really awesome surgeon that does a cool replacement technique where he'll put in like a little pin to re-anchor the thumb to alleviate this arthritis. And he has really awesome outcomes and it's pretty non-invasive. And these folks go from having a lot of pain with use of their typically dominant hand to not so much. It's kind of a long rehab process. We start totally immobilized and start with gentle motion and then can progress to strengthening after a couple of weeks. But it's a cool one to also talk through like, hey, we have to retrain how your thumb moves now because you've haven't had a stabilized thumb in years. And now we need to take care to strengthen those stabilizers to retrain how you're pulling away from the palm to grip, to grab, to move anything in your life. And this definitely comes from my mentor because she is a big CMC arthritis stan, loves thumb stability. And she is in her 60s. So she's always taught me from the get-go that I have to protect my thumbs in all of my treatment sessions and cutting splints, using splints, all of that jazz. So I think that it also just translates into our day-to-day lives. So that's why it's slowly becoming one of my favorites too, because I'm trying to also retrain myself on the preemptive side of how to correctly engage some of these stabilizers of the thumbs so that I'm not in that boat one day.
And kind of going off of that too, very OT focused kind of diagnosis is going to be conservative management of thumb CMC arthritis, because that is all talking for the most part, because we can never get rid of someone's arthritis, but we can help to maintain function and prevent the progression of that arthritis through education. So that's also a lot of like routine habit change through education on joint protection, energy conservation, looking at, different splinting options, because if we can't regain back that stability in the thumb, sometimes we need an external force to do that. So we're looking at either soft splints, hard splints, 3D printed splints. So that's something also Rush offers is kind of an introduction into 3D printing for either splints or adaptive equipment. So if that's something that you're interested in, that's kind of another cool thing that Rush offers, and that I even kind of have been seeing out in the hand therapy world. So, although we probably didn't give you a specific hand therapy treatment, it does also look biomechanical some days. I'm like, you have really weak wrist extensors, we need to strengthen them. So we're doing, flex bar bending. We're breaking out the little weights. We got putty exercises. We're squeezing, we're pinching to isolate certain muscles in the wrist to get an outcome that then allows the patient to be functional. So it really, again, it just depends on the day. It depends on what the patient needs.
Wonderful. We have a handful of questions in the chat. So one is, what assessments do you commonly use for hand injuries or conditions?
I can rapid fire a couple here quickly. Obviously, range of motion, manual muscle testing. We do all the dynamometer grip testing as well. Monofilaments for sensation testing, two-point discrimination. We also will do the DASH, the like outcome measure. We use that all the time in our clinic, especially to get that like functional piece tied in. I think those are the big ones that I use daily. There's always some other like fun ones that we'll throw in based off of like provocative assessments. If somebody has had symptoms of lateral epicondylitis or nerve impingements throughout the upper extremity. One that I've come to love the past year is the upper nerve or upper limb nerve tension testing, where you like really get to see, okay, where is this nerve being impinged, and potentially how can we release this or give you some semblance of pain-free motion again. So I think that it just depends on the person when you get into those like more niche special tests.
And those assessments, like you'll learn like goniometer, range of motion, probably like manual muscle testing in your courses. And then typically some of these, more niche assessments, you're going to learn kind of on the job during your clinical rotations or during your career. So like there are still probably hundreds of assessments that I don't even know, like the special, ligament wrists, tests. Like there's so many. So you're always learning in hand therapy too. We also use the DASH or the quick DASH. So we use the shortened version. It's disability of the arm, shoulder, and hand. And I actually use that in my capstone research project too. So insurances love it. You're probably going to see a lot of it. Typically, patients will get it at evaluation, and then we'll reassess it kind of in subsequent visits, progress notes as needed. But it is a nice assessment of, technically it's self-reported disability. But I always tell patients like the limitations you might be feeling, and it taps into a lot of functional activities. So how much difficulty are you having opening a tight or new jar? Difficulties with recreational activities, to what extent over the past week has this impacted your social activities? So it's a nice kind of conversation starter with patients as well. And then you can track that number over time.
Thank you both. And then kind of to wrap us up for tonight, we have our last question of, have you dealt with imposter syndrome either as an OT or specifically in hand therapy? And how have you dealt with that?
This is a fantastic question. I think this is one that I feel imposter syndrome daily, and I felt it daily as a student, feel it as a new grad all the time. it's something that comes with the field. I think every setting throughout, we feel this. That being said, I try to deal with it by reminding myself all the hard work I've put in thus far, everything I do know. I remind myself that, you know what, I'm confident and I know I'm going to do no harm. I remind myself of precautions, of things I need to know about this patient or whatever is causing me the imposter syndrome to begin with. And I do what I know and I go from there. And I think that sometimes just taking the step back to remind yourself who you are and what you know is the best medicine.
Definitely. And sometimes you also have to tap into the fake it till you make it. And as long as you're not doing harm to the patient, you're going to try something and you're going to go home and you're going to be like, that just wasn't right. And then you see the patient in 2 more days and you're able to kind of make a change on that. So typically it's a very low risk setting. You're not mobilizing, transferring patients, but we do want to ensure the safety of, the patient's tendons, ligaments. Yeah, I agree. You were educated in this. You're always going to be learning. I remember when I was job searching for my first job right after graduating, I called Kelly at Midwest Orthopedics at Rush. And I was like, I can't do this job. Like, I need a fellowship or I need more. And she goes, no, you're fine. Like, I don't know everything. And I was like, okay, good. And if Kelly is saying that, Kelly's like the smartest person I know. So you're right. Like even therapists who are, 35 years of practice, they still don't know everything. And you are the expert in hand therapy. You have that job, you have the education to back it up. And so sometimes I do need to remind myself that too, because I have imposter syndrome every once in a while. So, but we are educated and we know what we're talking about, and you can always adapt on that, and you can always learn more.
Absolutely. Absolutely. Thank you, Carly and Chloe, so much for your time tonight. I've learned so much from you. And it's just wonderful getting to hear about all your experiences, what you know, what you're learning, what we're all figuring out. So I loved it. Thank you so much. And Chloe and Carly have both graciously left their emails in the chat in case anyone is interested in emailing them with any additional questions, reaching out. Clearly they're both wonderful human beings. Thank you everyone for joining us tonight. This concludes our alumni Q&A. I am happy to stick on a little bit longer if anyone would like to chat or needs anything. Carly and Chloe, you guys are welcome to stay as well if you would like, but I understand that it is 7 o'clock and dinner sounds nice right now too. Thank you everyone.
Bye, everyone. Thank you for being here.
Bye. Thanks, everyone.
Thanks,
Thank you,
Carly.
guys.
Thanks, Chloe. Nice to see you.
Yeah, nice to see you guys too. Thank you so much, Daniela, for putting this together.
Yeah, this is awesome. I
Yes.
miss Rush. I miss Chicago.
I'm gonna have to tell Kelly you say hi tomorrow when I see
Yes.
her.
She recently just wrote me a letter of recommendation.
Oh my
So I've
God, she's
been
the
bugging them.
best.
She is wonderful. I
Yes.
miss Rush and like Midwest
Aw.
Orthopedics like every day. I'm like, oh,
Well,
hi.
we're here if you ever want to come
I
back.
know that's what Kelly said. And then I was talking
Yes.
to my supervisor at Northwestern too. And she was like, do you want my old job? And I was like, girl, I kind of do. So
Maybe.
yeah, no, Rush, I miss it there. So great experience.
Well, we
Yeah.
miss you.
Emmanuel, did you have a question that we can help answer for you? I don't know. No, he might not be able to mute.
I think he was a nursing student.
Yeah. Okay. I just removed him.
Thank you. I was about
Every
to
once in a while
message
we get
you like,
people,
can you just remove?
Yeah.
every once in a while we get people who,
Somebody floats in. Yeah.
register for the wrong info session. They just look for the date that works for them and they don't pay attention that all the programs are listed from the university. So
Right.
yeah.
He's gracious about it
That's
though. It was
nice.
nice. But yes, thank you both.
Yes, thank
Again, like this
you.
makes me like
You.
happy. Like this is exactly like the outcome I want it to have for alumni is like
Yeah.
look at all the connections like you still have and like can still make. And like again, OT is such a small world. I know our students don't always believe it, but it really, really is.
Absolutely.
Yes, no, it really is. But yeah, I think, and I'll probably reach out to, and Michelle and I guess like Bridget too, but I feel like once I sit for my CHT, I want rush students as field work. So wherever I am, you'll be hearing from me soon. So
That'd be great. We'd love it.
I'm
Yay.
picky. I only want rush.
Yeah,
People are, I don't,
definitely.
yeah.
Then CC like send. You could send it to Bridget and CC me and Piper Hansen.
Yeah,
Yeah,
Piper. Yeah.
yeah, for
Yeah.
sure.
Cause yeah, I feel like I don't know if you get this, Chloe, but like I feel like people are always surprised and like, oh, I've only been doing this for 2 years. And I think that just speaks very highly on Rush's education that people
Yeah.
think I've been doing this longer than I really have. So
Mm-hmm.
Yeah.
I also
That's
feel
our
like
goal is to prep you guys, so
I
that you hit the
know. No,
ground
like
running.
I felt very, very prepped. So
yeah. Well, and it's so nice. I feel like it's kind of a flex when people sometimes they'll come in all hot and heavy and be like, well, where did you even go to grad school? Like you look so young or yada. I'm like, I went here, I went to Rush. And they're always
yeah.
like, oh, like it always gives me a bump up. So I'm like,
Yeah.
I'll throw that in any chance I get.
Yes,
It
yes.
does. Whether it's like clinician or patient, like, oh,
Yeah.
It's like, well, I was trained by you guys, so
yeah, like
I was
actually
trained
born
here.
and bred pretty much.
Yes, yes.
Yay. Oh, that's excellent. And I'm so glad like I don't know, these sessions just like bring me so much joy.
Me
So
too.
glad that you
It's
guys
so
like have
nice.
gotten a lot of it. Again, it seems like a lot of our
Mhm.
participants did too. And again, I don't know where this journey of the Q&As will take me, but if you guys ever want to do a part two, I am more than happy to host you guys again. You guys are so wonderful.
Please reach out. I'm
Yeah,
always happy to brag about hand therapy. So,
Yay. Well, thank
yeah.
you
absolutely. Thank
both.
you.
All right. Well, thank you guys. Have a good
Yes,
night. I'm
of
gonna go
course.
watch the Timberwolves now. So,
Enjoy, enjoy.
thanks.
Bye, guys.
Bye, all.
All right,
Bye.
see you later. All right, Daniela, do we need to chat at all, or
I think we're good.
yeah, the next one is what? June
Oh goodness, I gotta start
June
looking ahead.
June 25th, right?
I believe so.
And
Sorry, let me
it's
quickly.
OTs working in inpatient and skilled nursing.
Yes.
Is that right?
Yeah. Sorry, just let me make sure I have it like completely right. Yes.
Okay,
Skilled nursing and
because
inpatient.
that's what I put in the email.
You're really good. And that one is 6:25, 6 p.m.
Right. Okay.
Beautiful. Cool.
Awesome. Yeah. Thank you
Yay.
so much.
Yeah, no problem. And thank you again for your ideas. And I'm glad it's helping. There is a bigger turnout today. Again, I know some
Okay, we should stop
perspectives from
this
alum.
recording now.